Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Paul, we're going to talk about primary hyperparathyroidism, a topic that I feel much more clear on now. I don't know about you.
No, I agree, and I'm thrilled that we picked this easy thing to say over and over again for a short Medscape video.
Yes. Now, Paul, in primary care, you see a lot of calcium that is just slightly high. Can we just blame that on thiazide diuretics? And what do you think about that?
It's a place to start, Matt. I think as you're going through, starting to think about your etiologies, everyone thinks primary hyperparathyroidism or malignancy are the two that kind of roll right off the tongue. But it is worth probably going back to your medication list and making sure you're not missing something. Thiazides are a famous cause of this. I will say in some of the reading for this episode, they may just uncover it a little bit early. So patients are on thiazides who become hypercalcemic seem to go on to develop primary hyperparathyroidism anyway. So I don't think you can solely blame the thiazide. And then another medication that can be potentially causative is also lithium. So a good place to look first after you've repeated and really confirmed it is actually the patient's medication list.
Yeah, and Paul, we've done other videos talking about this. The basic workup: is it PTH dependent or PTH independent? Hypercalcemia, and on the episode we talk more about the full workup. But I wanted to talk about the symptoms because the classic symptoms. Our guest made the point that we don't see them as much anymore, or you might see kidney stones. Of course, we see those. People used to present very late in the disease because they weren't having routine labs. So the classic symptoms they were talking about, like osteoporosis, there were these like bone tumors that people would get, these brown tumors. People get nephrocalcinosis and people get kidney stones. So the bone and kidney complications are what really are considered the classic symptoms, which is not, I hadn't really thought of it that way because we're used to diagnosing it early now, I guess. Do you feel the same?
Yeah, no, I think as labs have started routinely reporting calcium, like this is more and more how it's picked up. And then there's the other aspect is as we're screening for osteoporosis and finding osteoporosis, more part of the workup almost always involves getting like a parathyroid hormone and a calcium level. So I think we're seeing these lab abnormalities before we're seeing symptoms, which is good, I think. But there's but it also makes things a little bit more diagnostically thorny, I think.
And she made the point that a lot of people coming into her office and when she's seeing them before and after surgery, she's kind of aware of these non-classical symptoms. So we talked about the stones, bones, groans, and psychiatric overtones. And the psychiatric overtone, she said that could be anything from just fatigue or irritability, dysphoria. Sometimes people just have like kind of generalized weakness that's very nonspecific. And she said sometimes these kind of things will go away after people have their surgery, and maybe they were used to it or they thought the symptoms were caused by something else, but after the surgery they go away. So there are these non-classical symptoms that are harder to pin down. I was surprised by that.
Yeah, I think she cites polydipsia and polyuria, which has seen a bunch of papers as well. So it seems like it can do anything, which is sort of, you have to take a good history, but none of those things in and of themselves is an indication for operating unless they have the classic either renal manifestations or the bony manifestations.
So Paul, the other thing we talked about is that there are these, some people can have a normal calcium and still have primary hyperparathyroidism, or they could have a quote normal, a PTH that's in the normal range, but they still have high calcium and that's inappropriate. So can you talk a little bit about those two situations?
Yeah, they're hard to say, but kind of easy to manage, I should say, just because you treat them the same way that you do as someone who has the elevated calcium, the elevated parathyroid hormone. So the normal calcemic, this is something I think we stumble across specifically with like osteoporosis screening, and we've talked about like on the show, like you see an initial elevated calcium, you work it up, and the calcium comes back normal, but the PTH is elevated, and you're like, well, shoot, now what? But it turns out, I think most endocrine surgeons say that the same indications for surgery for the classic form apply to these patients as well, and it probably helps with the bone outcomes, which I think is one of the things they follow most closely. The normohormonal, which is an awful word, is, I'm glad to see you using the quote fingers because it's not normal. Like the point being is that if you have hypercalcemia, you should have a suppressed PTH. So even if it's in the normal range, that is still relatively elevated compared to what it should be. So again, that's sort of treated in the same way as you would with your classic elevated PTH and elevated calcium levels.
Yeah. So for the listeners, if the calcium is abnormal and the PTH is not quite what you'd expect it to be, you can always ask your friendly neighborhood endocrinologist to help you figure out if they really have one of these conditions or not. You do have to make sure that they don't have just like a simple secondary cause like a low vitamin D. So you fix the vitamin D and then recheck the numbers and, see if they've normalized. But I have found a bunch of these edge cases, and I do find it helpful to confer with an endocrinologist, especially before you send someone to a surgeon to get their gland taken out. But this was a really fantastic conversation, Paul. Listening back to it, I was very proud of the work we did and our guest, such a great guest. So if people want to hear the full episode, they can click on the link in the transcript. And with all that, until next time, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.